Hello, everyone. Welcome to today's live discussion titled Dismantling Stigma for All, Addressing Physician and Patient Mental Health, Including Suicide Risks, which is part of our ongoing Overcoming Obstacles series. Before we get started, a few housekeeping items. Please note that this session is for informational purposes only, and you should consult a professional advisor for specific medical, legal, financial, or other advice. You can also find relevant resources to today's discussion in the related content box on your screen. And lastly, if you have any general questions or concerns, you may send them to practice.sustainability@ama-assn.org. During today's discussion, we will hear from industry experts, including those with lived experience, on how to dismantle the stigma around seeking mental health treatment for both physicians and their patients. Dr. Stephen O'Connor, the Chief of Suicide Prevention Research Program at the National Institute of Mental Health, will be a moderator for today's discussion. We will then briefly hear from our other experts, Dr. Christine Yu Moutier, Chief Medical Officer at the American Foundation for Suicide Prevention, Dr. Daniel Miller, practicing family physician and Chief of Graduate Medical Education and Behavioral Health Integration for Sunriver Health, and Dr. Scott Pasichow, Assistant EMS Medical Director and Emergency Medicine and EMS Physician at Southern Illinois University. Most of our day today will be for an open interactive discussion for you all to be able to interact with our experts. So we encourage you all to utilize the Ask Question box throughout today's live discussion for any questions you may have. You may also use the raise hand function, and we will call on you to ask your question. And feel free to turn on your camera if you'd like, but absolutely no pressure to do so. And we will really try to get to as many questions as we can today. And with that, I will now turn the conversation over to Dr. O'Connor.
Okay, thank you very much, Chris, and thank you for that kind introduction and for inviting me to be part of this important conversation. So, as Chris mentioned, I chief the Suicide Prevention Research Program in the Division of Services and Intervention Research at the National Institute of Mental Health. So, suicide prevention is a major priority for NIMH. We have multiple funding opportunity announcements that are specifically trying to reduce suicide risk and various populations across different points in the chain of care. One of the things that we're really hoping that we can talk about today is the extent to which organizations, clinics, and higher education can create safe environments for both the service providers and the service users so that they can openly share their experiences and receive adequate support in living their lives and dealing with whatever issues might come up for them. One of the realities is that, you can't be your own doctor, just like you can't be your own therapist. We all have our own confirmation biases. So it's really critical that there's the freedom for people to be able to not have to solve all their own problems themselves, but be able to share that with other people so that they can get some outside perspective. It's really crucial. So with that, turn it over to Dr. Moutier.
Thanks, Stephen, and to the AMA. It's great to be here and really excited to highlight this important topic of suicide prevention with a focus on ourselves. And what I will say is, as a psychiatrist and now the Chief Medical Officer at the American Foundation for Suicide Prevention, my journey into really devoting my whole life's work to suicide prevention at the national level now, as I trace it back in my own path, it really started with my own lived experience of struggles that I had while I was in medical school. And then, that sort of very deep personal experience of the mismatch between the culture around you and the environment and the real freedom to address your own mental health needs as health needs. I was highly sensitized to that because of my own personal experience. And then fast forward later, by the time, 10 or 12 years later, I had become assistant dean for medical education and student affairs in the School of Medicine at UCSD. By that time, there had been a series of physician losses to suicide, faculty physicians across all specialties. And so that lived experience, and then the experience of loss of colleagues, interestingly, as a psychiatrist, it was a little bit less focused actually on patient care and more about the community experience of how we can rise up and look at our policies and our informal sort of hidden curriculum, all the things that shape the sort of unspoken rules for and by which we engage with our own human health needs, our families' needs, all of the things that we face at work and personally. So I'm very excited to get into this because from my perspective, this is about a public health issue. We now have a growing body of science that informs the fact that suicide, while complex, is a health-related behavior and health issue. And if you keep that health framework on everything we do, not just with regard to patient care and suicide prevention, but for ourselves. And the last thing I'll do before I turn it over to Dr. Pasachow to say a few words, is that when it comes to our own health worker sense of well-being, mental health, and suicide risk reduction, I very much see these issues as a shared responsibility between institutional leaders and really, national leaders within the various health disciplines. And then, of course, us as individuals and what we can do for ourselves and for our colleagues. But we're limited by that until the environment changes to be a very fair and a place that is as destigmatized as possible around issues of mental health and struggle. So with that, I'll turn it over to Dr. Pasachow.
Hi, Dr. Pasachow, or Scott Pasachow, sorry. Yeah, I really appreciate, I think that was a great kind of lead into my experience as well. I come at this from a lived experience perspective as well. I'm a second year EM faculty at Southern Illinois University in Springfield, Illinois. And I did a EMS fellowship as well, so I'm an EMS medical director. And my approach to this comes from my own experiences as a second year resident. I struggle with anxiety and depression of, fitting in this and sort of feeling like I had a home within medicine and emergency medicine, feeling like a competent physician, which I think is part of everyone's resident experience, sort of ebbs and flows in that. And then at some point struggling with my own suicidality and feeling like while I had an institution that was set up to help me, there were still certain stigmas and certain perspectives that I had that prevented me from getting access to the help that I needed. And feeling like, if I take the time now to get the mental health care that I need to be a good doctor, to finish my residency, it'll impact my practice in the future and would prevent me from actually completing my training. And those perceptions were not accurate. But in having the courage to share my story, I found that a lot of people share that same perspective. And so that's really where my focus and my advocacy work comes from is how can we get rid of the pieces that are in place that might give someone the impression that there is almost a punishment at the other end, a limit on their ability to practice, and how true is that, which probably less than I perceived at the time, and what steps can we take to continue to dismantle that so people don't feel that same pull of, if I take care of myself now, it might impact my ability to take care of my patient in the future. So that's kind of where I come from and why I'm here to be part of the discussion and hopefully come up with some solutions. I will, pass it off to Dr. Miller for an introduction as well.
Thanks, Dr. Pasachow. And again, to everyone, just thank you to the AMA and to the team and colleagues here to have this discussion. My name's Dan Miller. I'm a family physician with Sun River Health in New York. We are a large federally qualified health center. And I think I'm here to bring kind of the community health center or a community health center perspective to the discussion. There's so many places and ways to enter this discussion. And when we were preparing for this, we talked about a number of them. I think I'll start by saying kind of the obvious that suicidality does not fall out of the sky on us or just appear in us kind of from no place on any given day. It's intimately related to our life experiences, including those of trauma, oppression, and struggling with systems of inequity and racism in our country. In community health centers, and I think, for everyone here, we're acutely aware that for all of us, our health is most powerfully influenced by, I think, what has come to be called social determinants or social drivers of health that include housing, employment and income, education, community safety and environment. And, it's the notion that essentially our zip code affects our health and our well-being even more than our own individual health behaviors or the health care we receive. And with that understanding, as we then deepen our understandings of systems and structures of inequity in our country, I think we come to realize that these same systems, these social drivers of health, housing, employment, education, community, are the same institutional mediators of systemic inequity. And so, to us, I think what we've come to call the social drivers of health is really a euphemism, and probably more accurately, what we're dealing with are the health manifestations of racism, poverty, and oppression, and how this relates to despair and suicidality. And I raise this to say, really, that I think our patients and our staff, I think, are frequently unaware of this context that we're all living and working in. And so when we experience despair, that's so common when struggling within systems of oppression, I think we all often feel that something is wrong with us, that we have some personal inadequacy or deficit, and we blame ourselves for our experiences of despair and hopelessness. And I think one of the most important things we can offer our patients and our staffs is this shared understanding that we're all living and working within these systems, and to create ways to bring compassion to each other, to bring these experiences to the forefront, and really address the issues of isolation, shame, and hopelessness that this all engenders. And I think as we get into this discussion, we'll talk about ways to do that. Glad to be here with everybody.
Okay, great. Well, thank you each for providing a little bit of insight into your unique perspectives that you bring to this discussion. And I would invite the audience again to please post your questions, and we'll get to those. We have a couple teed up here at the beginning. And so one thing I'd like to ask the panelists, could you just kind of speak to any types of advances that you've seen going on in suicide prevention or mental health in general? Things related to clinical practice, research, or changes in cultural shifts within clinics, or maybe some of the things that Dr. Miller was just talking about that are happening within the communities?
Well, I can speak to the fact that, again, I see it as starting out with investments in science and really looking for answers to questions about what drives suicide risk up. And it's a very obviously complex field of study, in the sense that there are individuals with individual factors, genetics, early trauma, environmental factors of oppression, as Dr. Miller was expressing, but that for individuals and populations, it's always a multifaceted pathway. And so, I think now that we're seeing some of those, not only scientifically informed answers about what drives suicide risk up, but we're also seeing treatments as well as community-based. So the full public health model is really needing to be applied with a scientific inquiry. And I think advocacy, and those of us with lived experience or who've experienced loss speaking out, that is all changing the culture. So we're seeing just major culture shifts with regard to opening up of attitudes related to mental health experiences as well as suicide related experiences. And now I think we're in a transition period as a society where we're trying to figure out, what does that mean besides for patient care, which is a whole other important topic, about how do we scale suicide preventive practice, not just in psychiatric care, but across primary care and in emergency departments. But for our own colleagues and ourselves, I see that as fitting in the public health perspective more as actually community-based suicide prevention. And so there are huge advances going on with regard to, I think, the general public's understanding that suicide can be prevented, that some of the old myths about weakness and other things that really are not borne out by the science are being cleared up. We're seeing engagement with industries far outside of healthcare, with entertainment and news media and now workplace suicide prevention is a very growing and hot area of interest, believe it or not, in the construction industry. And, so I'm talking like way outside of healthcare. So that is all very exciting, but I think we are still really trying to figure out what does that look like boots on the ground to make a difference for people as they're facing these real issues, and to make help available, and even better, to not wait until crisis is happening, but to work far, far upstream, create environments that are open, equitable. And again, for me, it's an issue of, is mental health being treated as a health issue? Because if it were, we would not be having to look at those punitive consequences as even in the realm of possibilities with regard to, medical and nursing, licensing, and hospital privileging.
Yeah, thank you. Dr. Miller?
Yeah, if I could join here, Christine, I think you're naming it. I think you're naming it beautifully. And I want to just appreciate the comment in the question box from Peter. Sharing this. Peter, words are tough here. Very, very painful experience, and naming this and sharing it with us here in this community. Christine, I think as you're saying, there's so many levels here. There's, how does one create the places to respond to crisis? And as you say, how do we change culture way, way, way before crisis? And obviously changing culture is slow, but crucial. So, I'll name a few things that we're doing in our own system, and I think we're not alone in any of this, and partnering with many others to do this. So, a number of years ago, we instituted what would get called Schwartz rounds. I think there's many names for this. We used to call them Ballon groups, in the old days, and as somebody else put in the question box, of talk circles of where are the places to create safety for us to come together as a community to speak from the heart and feel support and compassion for the places that are tender in us. And as we do that, and as we share our own difficult experiences, I think we begin to open up the experiences of isolation and hopelessness that are so central to suicidality. And Christine, as you're saying, to make these conversations, to let them be normal, because they are normal, and because the experiences of despair and pain are normal experiences. It's the isolation and the shame and the hopelessness that brings that become much more difficult. And so we do those every month, and we open them up to everybody. And then we do those sessions also at times that we know are tougher. In one of our pediatric practices, over the course of 2 months, 2 babies died in the office, which are, enormously painful experiences for staff. Those things almost never happen. And so we know that people are carrying around pain, and some are carrying around the thoughts of, maybe if I had done something different, and blame. And so then creating those times and places to come together to say, this is a time for us to join as a community with our hearts and, and our souls, and be together. And I think creating those spaces is one of the places that helps create a different culture.
Yeah, I agree more with what you both really just touched upon. I certainly have had a very positive experience to sharing my story and my struggle, and seeing the number of people that I had no idea were going through a similar experience around me. And I think the theme I've gotten from some of the stories after the fact is that there's commonality between all, but the approach that works best for someone to actually be a successful intervention is going to be slightly different, and that time matters. And so I say that for two reasons. One, whether it's peer-to-peer, some sort of a group therapy session. I've also seen models that look at scheduling as part of your clinical hours, an hour once a year. I've actually seen a therapist, and actually sort of strongly encouraging that interaction. There's definitely been some impact, and there are a couple of pilot studies that have looked at that, just scheduling it as part of a resident's regular schedule, so it becomes an opt-out, as opposed to me having to stand up and raise my hand and say, I want to participate in this. The expectation is that everyone will participate in some level, and if you choose not to, you have the ability to. Obviously, we don't want to get rid of individual choice, but sort of putting your thumb on the scale a little bit and saying this is something that we think is important for people to participate in. Some months are going to be better than others. Some periods of time are going to be better than others. So kind of varying that schedule of, when the peer-to-peer session is, and realizing that just because you have one and not everyone attends, or no one attends the first time, that doesn't mean that it still isn't an important thing for you to continue. Sometimes low attendance or low uptake initially is just feeling out the process, and any one or two people that you can help can really have a huge impact on this.
Yeah, thank you. So just kind of piggybacking on that, just very directly, what do you think that physicians should do if they notice signs of mental health worsening or suicide intensity in themselves?
Well, I think, this is really to make it very down to earth. Not everyone is necessarily ready to, to speak with their physician or to find a mental health professional, although that is, of course, a very highly recommended strategy, because while having suicidal thoughts is actually very common in the general population and in us as a healthcare professional community, it does signal a very serious level of distress. So I would, on the one hand, absolutely agree that distress and despair and all kinds of experiences with regard to our mental health are so normal, are so common that we can call them a normal part of the human experience. But it does signal that it's time to reach out and take a step. And so I just say to colleagues, think of one person who's made it clear that they are a safe person. They're trustworthy, that they've been through something themselves, that they'll be able to, just practice active listening skills and hear you out. And that might be your first step, whether it's a colleague, a mentor, somebody outside your professional workplace is certainly fine. I think any pathway that feels safe to you, where you can take that first step and begin to express what you're experiencing. I think sometimes we wonder, what will talking about our distress do to help ourselves? And I don't want to, load that on anybody else. But the fact is that the suicide prevention science tells us that interpersonal connectedness can make a huge difference, and that disclosing what you're actually experiencing can be the first step of normalizing that we can reach out and get help. So, I think that for all of us, there are safe people in our lives. And I think beyond that, of course, know that there are crisis resources that you can always reach out to via 988, and ones that are clinician or even physician specific that are completely anonymous and safe to do. The physician support line, for example, being one.
Christine, I want to agree and just add just the little bit, and maybe just say it in my own words, but, as you say, what we do is hard. And so there's a lot of times when we all struggle. And when we get to that place of contemplating hurting ourselves or dying by suicide, it's a real marker to us. When you see, Stephen, what do we do when we get there? It's a time to ask for help, and it's a time to reach out, to let go of the notion that we're supposed to manage this all ourselves. And whether it's a colleague or a family member or a therapist, that the first step is to not be alone in this and ask for help, and to just say, I need some help here. And I think that's the beginning. There is no expectation that we're supposed to manage and carry this all internally ourselves.
Yeah, thank you. And so maybe Dr. Pasachow, you could pick up this next question, because this conversation is kind of building on itself, and I think we're just sort of deepening, where we're going with this. But I think that, an observation could be made that the decisions, the behaviors that people display are kind of a reflection of the learning that's occurred. So if you're looking at physicians in the workplace, they've sort of, they're an encapsulation of all the messaging and the learning that they've gotten to that point about how to understand their own experience and maybe the choices that they're making. So discussions like this are trying to help inform culture change and differences in behaviors in terms of reaching out. But there have been questions from the audience about what's happening upstream, early in medical education, that can contribute to, maybe different decisions by physicians that potentially could save their life.
I mean, I think conversations like this, either in a large group setting or even in a smaller setting, is really the key to it. Not just waiting for the individual to self-identify if they're having these struggles, find someone to reach out to, but when you have had success in working through it, sharing that story, or even if you, as one of the questions was asked, had a struggle with your own family and had an outcome that you didn't like, and you want to make a change for the future, just being a place to say, this was my experience, and I want to do something different, and I hope that there's a different outcome for the people around me. And just taking that moment of sharing that story really creates a connection in the people around you, and they don't feel that you as an individual are the person that they would go to. It helps to normalize the fact that there is help out there, and that there isn't going to be repercussion on the other end that some people might be fearing, of a licensure action or something like that. That if you take care of it, in the moment as it's happening, you can mitigate a lot of the downstream effects. And I think there's also been a fair amount of pressure from the AMA, from the Federation of State Medical Boards, to say, when individuals are caring for their mental health no differently than their physical health, we need to not be punishing them on the back end, and removing questions that don't provide useful information from the medical licensure process. And that work has been happening over the last decade and continues to happen. And the more conversations we're having in this space, and the more people are talking about their experience and the value that it brings, is really, really important.
Wow, what a fantastic discussion. Thank you again, Drs. O'Connor, Moutier, Miller, and Pasachow, for sharing your incredible insights, expertise, and experiences with our audience today. And thank you for viewing this discussion. Please take care, stay healthy, and stay safe. Thanks so much.